This is a case of a 62-year-old female who came in with a total retinal detachment in her right eye. On examination, there were multiple breaks, but they were quite posterior, just near the equator. There was some vitreous hemorrhage also, which looked to be trickled heme from the edge of the breaks. Hence, we advised her a vitrectomy endolaser with a silicone oil injection. The surgery was started with a 25 gauge hypervit system. The vitrectomy was started and multiple breaks were located near the equator. It is very important in these cases that the edges of the break have to be absolutely clear of any kind of vitreous. Along with that, certain breaks are actually horseshoe tears and they might have flaps like this one. Hence, the flaps have to be cleared so that there is less chance of a recurrence because of traction through the flap. A peripheral base dissection was started. While doing the peripheral dissections, a few more breaks were noted. These breaks were actually marked with the help of a cautery. Since there are so many horseshoe tears, it is very evident that the PVD is already present, but it is very important to make sure that the PVD is induced at least till the anterior margins of these breaks. Now, one of the superior breaks is used as a base break, and with the help of a flute needle and FAX, that is fluid air exchange, the subretinal fluid is gradually and slowly drained out of the break. The subretinal fluid drainage procedure with the flute is slightly slower because it is a 25 gauge system, but patience is a virtue here, and you can beautifully see the SRF coming out and the retina settling down. Once this is done, an endolaser is started. Now there are two options here. One is to just laser the breaks that are seen, and second to laser 360 degree. When I was doing the peripheral shaving, I could see tiny culprit breaks at the periphery, and since I have not placed a 240 band to support them, I planned to laser 360 degree in this case. Sometimes while doing the laser, you might not have these white marks. So there is a chance that there is again a seepage of fluid subretinally. So in this case, again, you have to take your flute and drain all the fluid out through any of the break, preferably the most dependent one, and then restart the laser process. Once the laser is over, it is time for air oil exchange. There is always a controversy whether to use gas or oil in these cases. Although I knew my PVD was completely clear and the vitrectomy was quite meticulous, the patient's other eye was already compromised, so this was nearly a one-eyed patient. Hence, in these cases, I tend to use silicone oil. The patient regained 6/18 vision post the surgery, and this patient was advised a silicone oil removal after 3 months. Thank you very much for watching.